Hello, everyone. I am Dr. Keith Burke. I'm a professor of behavioral sciences in the Alcohol and Other Drug Studies program at San Diego City College. The AODS program is a vocational or job training program offered at the college, meets all of the state requirements that are necessary in order to sit for the certification exam to be a drug and alcohol counselor in the state of California. The AODS program is fully accredited. You get college credit for taking the courses. Today, I am going to give a lecture on assessment of family systems in substance use treatment. Assessment is covered in a number of the courses in the AODS program at San Diego City College because assessment is so important. Today, I'm going to speak particularly about how to assess a family system when you're doing family counseling in a substance use treatment facility. But we're also going to review some of the basic principles of assessment right here at the beginning because assessment is so incredibly important in the work we do as alcohol and drug counselors. So what is a clinical assessment? In order to develop a plan to effectively treat a client and their symptoms and concerns, the clinician must first do an assessment. An assessment refers to the gathering of information about the client's situation and their symptoms and determining what the primary concerns are that are contributing to the problem. Now note that a clinical assessment does the same thing whether you're an alcohol and drug counselor, a licensed mental health clinician, a psychiatric nurse, a medical doctor. It's the same basic idea. A client comes into treatment, presumably because there's something going on. And before we jump in and kind of willy-nilly try to start solving problems, what we need to do is figure out first, what exactly is the situation? What are the problems, often plural, that are happening? And what are the primary concerns? Obviously, in substance use treatment, we're very interested in problems or concerns that are contributing to a substance use disorder or a potential substance use disorder. What will happen then from the assessment is we use this information to develop the treatment plan. And the treatment plan is used then to intervene and structure the treatment sessions. This is how that works. The process of doing the assessment and the treatment plan and then your interventions is sometimes referred to as the golden thread or the documentation golden thread. The idea is that the golden thread links together all the relevant clinical information about a client and their treatment. And the assessment, both the initial intake assessment and ongoing assessment, is a key domain in that documentation golden thread. So the assessment is the first part of the golden thread where we identify what the problem or the concern is that's going to be treated. Once we've identified what that problem is, then we develop a treatment plan. A treatment plan is a series of identified goals that are worked out with the client that you and the client are going to use to try and address the particular problem. I will give there is another lecture on treatment planning where we get into treatment plans in more detail. And then the third dimension of the golden thread are the progress notes. So the progress notes are the documentation that demonstrate that the interventions, meaning the deliberate actions that the clinician does with the client to address the problem, and the services provided match what's in the treatment plan. And the treatment plan links back to what the problems were that were initially assessed. It looks like this. So the assessment will naturally lead to the treatment plan. The treatment plan dictates what happens in the sessions. Now the golden thread actually links going back the other way too. So when a clinician intervenes in a session, they're expected to be doing whatever they've agreed to do on the treatment plan. That takes care of the problem of the day phenomenon, where a client comes in and the clinician says, so, how's it going? How was your week? What's up? What's happening? That is frowned upon both from a best practices perspective. It is definitely frowned upon from a funder's perspective. The goal of treatment is not to just figure out what's happening today and see if we can come up with something in order to address that. The idea is that individual sessions will be structured by what's on the treatment plan. So what have we agreed to work on? How have we agreed to work on that? And then our sessions are used in order to either implement that work or review that work or modify that work accordingly. But sometimes what will happen is in session, some new problem or concern emerges that wasn't identified previously. Maybe the client wasn't feeling comfortable with the clinician or the treatment facility, and there was some very significant clinical problem that they withheld and didn't bring forward, and now they're starting to feel more comfortable and they bring forward. So the idea here, though, is that the progress notes will capture the emergence of whatever that new problem is, but that new problem, if it's significant enough to work on in treatment, needs to be added to the treatment plan. And in many agencies, there is a supplemental problem list, or assessment document in which the new problem can be identified as a priority concern in the treatment. All right, so let's go back to assessment, the first part of the golden thread. The basic process of doing an assessment is going to be the same whether you're assessing an individual or a couple or a family or a group. The first thing that you do whenever you're doing an assessment is to try to get information that's used to identify the potential issues or concerns, and you do this through a series of questions and observations. Once you get the information, you then summarize or repeat back what you've identified to ensure clarity. Meaning that if you are assessing a client or a couple or a family system, we need to repeat back or summarize what we've learned during our assessment to make sure that you, the clinician, have it right and the individual, the couple, the family sees it the same way. I like to use the example of a plumber. If in my house, suddenly my carpet is soaking wet in my bedroom and I can't figure out why my carpet is soaking wet because there's no sink in my bedroom, I may call a plumber. And if the plumber comes out and they look and they say, yeah, do you mind if I go see what's in the other room? And they go in the other room and they ask if there's an access panel on the wall. And then they go into the bathroom and they turn the water on and off, right? And then they look around. The plumber, if they come back and say, okay, great, I'll see you next Tuesday. Then you, the consumer, are going to be like, whoa, hold on a second. What's going on here? Like, I called you out. Why is there water in my bedroom? So it doesn't happen that way, right? What happens is, you have a concern, you contact a plumber, the plumber comes in and does an assessment to try and figure out what's the problem, why is the water here? And then what the plumber will do is say, okay, so I think I know what's probably going on. You see back here in this wall, on the other side of this wall is where the bathroom is. There's actually a set of pipes running through the wall. There's a valve. I have a feeling that what's happened is, maybe there's a leak probably in the valve, but I'm going to need to open up the wall in order to ensure that. I may be able to just repair the valve, but it could be that we actually have a rupture in there, in which case it'll be a bigger deal, yada, 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 right? So the plumber then repeats back or summarizes what they've identified as the potential problem. And then the next step of that is going to be identifying or establishing the initial goals that you're going to work on together. So if it's the plumber is going to say, so we've got a couple options here. We could open up the wall and just look to repair the valve. That may work for the short term, or these are old pipes. Your house is 60 years old. One of the things we might want to consider is replacing those pipes with, I don't know, I'm not a plumber, but some new metal or PVC that's come out. And then they ask you, the consumer, how do you want to handle this? So that's the same thing that we do in clinical work. We do an assessment where we gather information to figure out, well, what's the problem? What's the concern? Why is this person here in treatment? Through that process then of doing the assessment, we figure out the initial picture of what the concerns are, and then we are going to summarize and repeat back to the client. Okay, so based on what you've said to me today, it sounds like A, B, and C have been major concerns for you. You've tried this before, this hasn't been working, et cetera, et cetera. And then what we're going to do is say, all right, so there's a couple things that we can do to address this, and we should probably figure out what's the priority. And then we talk to the client and start to move towards identifying and working on the things that'll go onto the treatment plan. Now, it can be helpful sometimes to see an assessment as creating a type of information map. You're going to use that map to plan where the treatment will initially go. If I were going to plan a trip this weekend with my wife, and I say, hey, let's go away this weekend, and she says, great, where do you want to go? And I say, you know, let's go out to the mountains. Maybe it'll be cooler there, and it's the fall and the leaves are starting to change colors. Well, we could just get in the car and start driving, right, and head in the general direction, and hopefully we'll end up there. But typically what we're going to do is say, okay, let's look at a map. Where exactly do we want to go? There's lots of mountains out there. Do we want to go to nearby mountains, far away mountains, this mountain, that mountain, etc.? So once we look at the map to figure out where we're going to initially go, then in this example, my wife and I are going to discuss this and make sure that we see these things the same way, and there's general agreement about the direction in which we're heading. I live in Southern California. I may say, well, I'm thinking we should go to the Sierra Nevada mountains. That'd be beautiful this time of year. And maybe my wife says, well, that'd be great, but that's about 6 or 7 hours away. What about the local mountains here in San Diego County? You know, it'd probably be pretty nice there. And we say, well, yeah, that'd be shorter. Well, which ones would you want to go to? And we're looking at the map and we're trying to figure this out. And then once we come to an agreement, got it. So we're going to go to the Laguna Mountains in San Diego County, which won't take as long to drive. And now we have a map and a plan of where we're going to go. That's essentially what you're doing in an assessment. You're creating a map based upon the information that you get. You're going to discuss that map through summarizing and letting the clients know what you've observed. And then you're all going to come to an agreement about what direction you're heading to. In doing assessments, there are different types of assessments. There is the initial or the intake assessment. There is always going to be an initial intake assessment when a client first enters a treatment program and or when the clinician first meets the client. At least if you are in a certified or a licensed substance use treatment program in the state of California, there must be an initial intake assessment that's done when the client first gets there. The initial intake assessment is going to be what's used to create the initial treatment plan or the first treatment plan. The initial intake is typically structured, meaning that it is a form or a formal questionnaire in which all clients coming into the program are asked the same questions. You can fill out forms as you learn more information and use those questions to guide what types of questions that you want to have answered. Meaning that the form itself kind of dictates what information you're trying to go for. And then what happens is, as you're doing the assessment, you are filling out that form, either as you go with the client, you know, or after you've done that interview with the client. Now, structured assessments still require supplemental questions and observations for accuracy, meaning that a question may then demand a follow-up question. You may have on your structured intake assessment, have you ever previously been in substance use treatment? And the client may say, no, well, I mean, I don't think so. What do you mean by treatment? Obviously, that's going to require a follow-up question. Well, what I mean by treatment is any kind of formal treatment. Maybe the client says like a detox? Does that count as treatment? Yeah, exactly. A detox would be a type of treatment. Oh, okay, yeah. I was in detox actually once, but I didn't go to treatment after that. They wanted me to, but I went back home. So I have to ask a supplemental or a follow-up question. Maybe I'm in a section of the intake assessment and I'm trying to determine what the drug of choice is. You know, what is your principal drug of choice? And maybe the client says, oh, I use everything. Well, instead of putting everything in there, the clinician may need to ask a follow-up question of, okay, so you use everything, but what would be your drug of choice? Meaning that if all the drugs were laid out on a table in front of you, which one would you pick up first if you had the choice? Oh, okay. Well, I mean, I guess if all of them were there in front of me, then I'd probably choose heroin. Okay, got it. So heroin's the drug of choice. So that's a follow-up or supplemental question for accuracy purposes. In addition, observations play a key role in any kind of formal structured assessment because the client's often going to give you additional information on top of what it is that's coming out of their mouth. So, you know, maybe the client, you ask the client, have you ever been in a treatment program before? And the client says, Yeah, of course. Okay, well, they're giving us a lot more information there, right? Obviously, there's some strong feelings about the fact that they've been in treatment before. Maybe the client's like, angry or upset or irritated with me or irritated about being there. I'm going to want to capture that observation. Maybe I'll go back to another example. Maybe you're asking the client about mental health symptoms. Maybe the client is sitting in front of you and they're obviously incredibly anxious and they're kind of twitching around, and you say, okay, have you ever been given a mental health diagnosis? No, nothing like that before. Okay. Have you ever had mental health symptoms? No, I don't have a mental health problem. Like, I don't just no, there's nothing wrong with me. Okay. So I'm wondering how you're feeling right now. It looks like maybe you're feeling a little anxious or a little upset. No, I'm not anxious. I'm not upset. Like, it's fine. It's fine. Just, God, can we please get it over? So if you were just recording what they said to answer those questions, it would say no mental health diagnosis, no mental health symptoms, client denies, right? But your observations are giving you different information. Clearly, this client is showing signs of agitation or potential anxiety, and so you want to be able to make a note of that too. The idea being that even when you're using a structured intake, you're going to need to use your clinical skills to ask the important follow-up questions and observations for accuracy purposes. There is also ongoing assessment. So clients are assessed when they first come into a program to develop the initial treatment plan, but lots of times you're not getting all the information at the first intake assessment. So assessment is done ongoing, and typically assessment will be conducted in an informal or an unstructured manner during all the client interactions throughout treatment, meaning that you assess the client when they first come in and you develop an initial treatment plan, but maybe in supplemental individual counseling sessions, more key information is emerging. Or maybe the client is showing up one way during individual sessions with you, but you're getting reports that in group, they're totally different. Maybe with you, they're being really collaborative and open and motivated, and in group, they're being antagonistic and they're yelling at the other counselors and they're withdrawing and they're refusing to participate. So that would be important information. Why is my client showing up one way in individual sessions and another way in group sessions? You are going to get lots of information when you see the client in a family counseling session. So you're seeing them as an individual in treatment, they're showing up one way, and then the family comes in and you do a family counseling session, and suddenly your client is showing up very differently than they were showing up previously. You also will do assessment in what's typically called the milieu, or in the milieu. So in the milieu simply means in the environment, in passing. So as you walk past the client and they're having lunch and you see them looking very angry and agitated, you're going to do an assessment right there. It may be as simple as walking up to them and saying, hey, what's going on? You look like you're upset. So what you're doing there is an informal or unstructured assessment in response to something that's going on. It's often said in our field, we are always assessing. The assessment antenna is up always, no matter what it is that we're doing, because we're always trying to determine if there's new and relevant information that's emerging that's going to be helpful to treat whatever it is that we're treating the client for. Now, ongoing assessment is typically done in an unstructured way. So an unstructured assessment means that the clinician is not following a written set of questions or a particular script. So a structured assessment on an intake, I might have a form. I take that form, I say to the client, hi, I'm Keith, nice to meet you. I'm going to be doing an assessment today. I'm going to be asking you a lot of information. We're going to use this to develop your initial treatment plan. And then you begin, question one, right? And you go through. That's the formal assessment. An unstructured assessment means I don't have a set of written questions or a particular script, but I'm trying to get information about what's happening there. In an unstructured assessment, it allows for more observations and situational response. Situational response means you're responding to an evolving or an emerging situation. Like, for example, maybe the client is angry. You see the client is angry, and so you go over there to try and figure out what's going on. Now, in an unstructured assessment, you're going to ask key targeted questions to get information. So if my client appears angry as they're, you know, in the dining room, in the milieu, as I'm passing them by. I'm not going to walk over there and say, hey, how's it going? Hot weather outside we're having, eh? Right? I'm going to need to ask targeted questions, but I'm probably not going to go with a written script of what questions to ask when a client's angry. So what I'm going to do instead is go over and say like, hey, what's going on? Nothing. Okay, it looks like you're upset and you're angry. You know, I was just noticing that you were yelling at a fellow client. Can I ask what's happening that's making you feel angry? So I'm asking targeted questions in response to a situation. Now, an unstructured assessment often allows for a more natural state in terms of your interactions with the client and the client themselves, and a more natural conversation flow. If I'm asking a structured questionnaire, that client's not really in a natural state. They've been brought in, they're sitting in a chair, they're answering question after question after question. This isn't the way they are naturally. But if I run into them in the cafeteria and they're angry, you know, my client might be, yeah, I'm fucking pissed off. Do you know what happened? Right, and they're agitated, and I'm seeing what they look like when they're angry. And I may have asked them previously in a formal structured assessment, you know, what do you do when you're angry? Oh, I just calm down really easily. But in this case, I'm saying like, okay, whoa. So like, I want to understand what's going on, but you don't need to yell at me and you don't need to swear. Yeah, well, what the fuck? What do you care? Okay. So like, deep breath. I'm wondering if we can just calm down a little bit. No, I can't calm down. This is great information for us for our assessment. What we're seeing is the client in a natural state and the conversation flowing as it naturally would. And it's giving us key information that in this case, maybe our client is not only angry, but is elevating very quickly, is unable to calm themselves. Maybe they're lacking coping skills, et cetera, et cetera. So the unstructured assessment is more flexible, and in many cases, it's able to generate more information. But the unstructured assessment requires more training in order to keep it on track. The clinical challenge in an unstructured assessment is to remember the purpose of the assessment. You're trying to get information that will be used in the treatment plan. That's the agenda. That's what you're doing when you're assessing a situation. The challenge is that clients in their natural state, when they're allowed to converse freely, will often move the conversation into areas that are no longer conducive to assessment and the gathering of information. So if I'm upset, if my client's upset and I'm trying to assess what's going on, is my client able to regulate their anger, and I go over there and they say, yeah, I'm really pissed off, this client's really upsetting me, and I say, oh, what's happening? And they say, well, you know, that client, you know, she was talking to Maria over there, and you know, Maria, like, I love Maria. Maria is really great. She has like 3 kids, and I have 3 kids too. And so like, we really like super connected. And I think Maria's like, she's like the bomb. And actually, you know, I hope Maria and I can be friends when we leave treatment. And yeah, so anyway, so Maria was talking about her eldest son, you know, like, so, and we've moved far away, right? I went over to assess why is my client angry. And now we moved into my client was angry at another client. And now we're talking about Maria, who's like a 3rd client. And now I'm learning all about Maria's kids. And I still don't know anything about why my client's angry. And so the problem with an unstructured assessment is that the clients may just roll off into an area where I'm not getting information anymore for the assessment. And typically the untrained clinician is going to tend to follow that. Meaning that without training, if you're doing an unstructured assessment, where the client goes, I'm following. So now the client's talking about Maria and Maria's kids, and I'm like, oh, okay, like, well, what's Maria doing about that? Like, yeah, I know, it's really challenging. And now I'm talking about Maria and her kids, and right, I mean, the lunchroom is closing, and my client's got to go to group, and I still don't have any information about like why she got angry and what the coping skills were. So we need to remember that when we're doing an assessment, we are not counseling. When we're doing an assessment, we have an agenda. The agenda is to ask key questions in order to get answers that are going to be used to come up with a plan to figure out how we're going to treat this client. That is often a big challenge for new and untrained clinicians, because the tendency is to start counseling clients when you're doing an assessment, and this isn't a counseling session yet. You don't want to problem solve. The purpose of the assessment is to gather information. not to work on solutions yet. And in many cases, you're going to need the full picture before you start counseling the issues, because you may end up counseling the issue that isn't a priority issue. So the most important part of training when doing an assessment is to stay on track, get the information, or develop the treatment goals. That makes the assessment a different kind of session with a client, a special and unique session with a client. And it's considered best practice to educate the client on what you're doing before you conduct an assessment. Often when I'm meeting with a client, I'll say something to them. When I'm meeting with a client to do an assessment, I'll say something to them to the effect of that, where I might say, hey, I'm Keith. I'm here today to do your assessment. I'm going to be asking you a series of questions. We're going to use this information to try and figure out your treatment. So as we're talking, things may come up that you may want to tell me more about. And I will definitely appreciate that you may really want to have some space and time to talk about it. Today's a little different, though. I have an agenda. I've got to get through all of these questions that are here on this form, and we've got to accomplish this in the next hour and a half. So if we get to the point that new information is coming out, I may stop you, and then we'll return to that in a later date, or hopefully you can talk about that with your counselor when you meet them later on this week. And that can really help when clients understand, oh, this isn't a problem solving or counseling session, this is an information gathering session. Now, sometimes they're still going to look to you for answers. You may be doing an assessment and they bring something up and they're looking at you like, so I don't know what to do about that. So the untrained clinician may just immediately launch into a discussion of like, well, yeah, I don't know. Like, what have you done about that previously? What's worked? Well, I'm not sure. Other clients do this. Now I'm not doing an assessment anymore. Now I'm doing counseling. So instead, what you want to do is respond with some variation of acknowledgement and then letting them know that you're putting that in the parking lot so that you can finish the assessment. So like, here's an example phrase here. Wow, I can see how that is a concern. I imagine we may want to make that a priority when we decide what to focus on during our time together. Let's hold on to that for right now. I'd like to ask you some more questions first to make sure I have the full picture of everything that's going on, and then you continue on with the assessment. All right. So that's the kind of a basic overview of what the assessment process is. Again, in the Alcohol and Other Drug Studies program, there are multiple courses in which you go over assessment, different types of assessments with different types of groups. Today, I'm going to talk specifically about doing a clinical assessment of a family system. In the AODS program at San Diego City College, we have an entire course on family dynamics and family counseling and substance use treatment. Family counseling is a critical part of doing substance use treatment, as everyone who comes into treatment has some kind of a family system. Now, that may or may not be blood relatives that they have, but they're coming out of some sort of a system. Maybe they're married, maybe they have their own children. Everybody's got a family of origin of some sort, even if somebody grew up, living on the streets as a homeless youth. There's still some sort of family. And so in the family class, we learn about how important it is to involve the family in substance use treatment, particularly involving the family in relapse prevention planning and establishing a safe family home environment that the client may return to. It's the same thing when working with families, though. Before we launch into doing clinical work with families, we need to assess the family system. So in the assessment of the family system, most of the time you will do an unstructured assessment. There are some structured intake assessment questionnaires that are used for family systems, but family systems are very complex. And in substance use treatment, it's not like you're going to have months and months and months of meeting with this family every week to cover all the key stuff. It's going to be really critical to figure out what are the priority issues, what can be worked on while one of the family members is in substance use treatment, what needs to be deferred or referred out to outside of treatment. And so the goal of doing a family assessment is to get a good sense, at least initially, how the family system is interacting with each other. And you want to then prioritize the family interactions that are problematic and or relate to the substance use disorder. And most of the time, there isn't going to be a formal or structured questionnaire that's going to hit those key things. most of the times you're going to need to do situational response to what the key issues are for this particular family. So the first step of doing any assessment is to identify problems. What are the problems? What are the concerns in this family system? So the first step when you're identifying problems in a family system is pretty simple and straightforward. You simply ask them. So, hi family, thank you for coming today I'll just use Maria, since Maria was brought up earlier. Thank you, hi, thank you all for coming today. As you know, Maria is here in our treatment program. We like to get the families involved in treatment, as a key part of the treatment. So I'd like to get to know a little bit more about you all. But what I'd like to do is just to start and maybe identify how you all feel about being here. Are there some things that you might want to work on while we're in family counseling together? So you're simply going to ask and see what they say. Most of the time, families have a list of issues or concerns that they're more than willing to talk about if we simply make a platform for them of, what do you want to work on? What are you concerned about? What stands out? What are the high priority issues? How would you like to use our time together? How can I be of assistance? Those kinds of open-ended questions will give you the low-hanging fruit, so to speak, of what the family is concerned about. So we ask. Now, asking about problems, there's a couple of things that we need to keep in mind. So one thing is that people are not always able to express themselves clearly or identify what their needs are. This is particularly true for the person who's in substance use disorder, because by the time people get into substance use treatment, typically they've been using substances for long enough that it has impacted their brain. You learn more about how drugs and alcohol impact the brain in our pharmacology course in the AODS program at San Diego City College, which I'm not going to get into right now, but suffice it to say that even after somebody has gone through the acute withdrawal phase of the substance getting out of their system, they still suffer from post-acute withdrawal, which is a period of time that it takes for your brain to get back online, so to speak. And so the person with the substance use disorder may not be able to express themselves and their needs clearly, but sometimes people just have a hard time with that too. So it may look something like this. I'm wondering if there's anything that you all are coming in with that you'd like to talk about in family counseling, or maybe something we can work on together in family counseling. And maybe, mom in the family says, yeah, I just, I appreciate the fact that Maria is getting treatment, and, it's not like, look, I'm watching her kids and I'm happy to do it because I'm really happy that Maria, baby, I'm happy you're getting like what you need right now. The thing is though, it's a lot, I have my own life and, and my own job and, I love my grandkids, don't get me wrong, but I don't know, I guess that's what I want to work on. So that's not very clear, right? It's going to be really hard to determine what it is actually that mom's bringing up as a concern. It's not like I can take that and put that straight into a treatment plan. And so we may then need to do some clarification and some repeating back. So in this case, it might say like, okay, so thanks, Mom. Let me repeat that back and make sure that I got that right. I think what you're saying is that while you appreciate the fact that Maria's in treatment and you support Maria being in treatment and you're willing to watch the kids while she's in treatment, it's also causing you some stress and you have some of your own things that you're trying to get accomplished in your life. Do I have that correct? Yeah, exactly. Got it. So when we ask what the problems are, that doesn't mean that we aren't going to do any clinical work. A lot of times our clinical work may be that we need to clarify and determine what it is exactly that's being identified. And sometimes people may say things and we may determine that there's some other problems that are being hinted at that the family isn't actually talking about. So we talk about this when we do treatment planning. There's lots and lots of ways that a clinician can get closer to figuring out what it is that people are actually trying to say. Now, there are some particular factors with families when we're doing substance use treatment and treating families in substance use treatment. One of the things that we can assume as an alcohol and drug counselor is that the family system is almost always going to be directly enmeshed with the substance use disorder, meaning that the family system is involved closely with the substance use disorder. Now, clearly, substance use is almost always impacting the family system. What's not always so clear, but is safe to assume, that the family system is also almost always impacting the substance use. I'll take a really simplistic example. I'll keep on Maria and her family. You know, maybe Maria's drug of choice is alcohol. And so Maria's drinking was obvious to the family system. But maybe Maria's mom wasn't saying anything to Maria, or she was kind of hinting at, like, you know, Maria, aren't you concerned about your drinking? No, mom, like, I'm busy, I'm working, I deserve to have a drink. Okay, baby, like, you know, I'm just checking. Like, Maria, I said I'd watch the kids, but I mean, you said you'd be home at 7 and it's almost midnight. Like, God, mom, give me a break. Like, you know, I sent you a text. Yeah, but you just sent me a text at 11:30. Like, I can't talk about this right now. Leave me alone. Okay. Well, in this case, right, Maria's substance use is stressing out the family system. It's stressing out her mother. It's causing issues with childcare, like, clearly. But at the same time, the family system might actually be impacting why Maria's drinking. Maybe mom is inadvertently enabling Maria's drinking by not setting down clear consequences. Maybe Maria is legitimately stressed out. Maybe she's a single mom and she is working and she has kids. And the only way that she can deal with that, you know, is by drinking, which temporarily makes her feel better. And so the idea when we're doing family counseling is to recognize there is going to be some impact of the substance use on the family. We need to figure out how that's impacting the family system. But we also need to figure out how the family system is impacting the substance use. We're going to have to ask questions related to that. So the goal of the family assessment is to identify both factors. So if the family doesn't bring it up themselves, there are some common substance use disorder problem scenarios that we want to ask the family about. One is, who's the family's support system and do they have one? Typically what happens in families when a substance use disorder starts to get out of control is they stop talking about it. You know, if my wife is developing an alcohol use disorder and I don't know what to do about it and it's stressing me out, you know, and my friend calls me up and they're like, hey, how's it going? I'm probably going to be hesitant to bring up, like, hey, it's pretty bad. My wife's alcoholism is really getting out of control and I don't know what to do about it. Some people may have a support system, but research has shown typically what happens is family systems start to close the ranks and their circle of support gets smaller and smaller and smaller as the substance use disorder gets more and more of a problem. So we want to find out, what's your support system? Who do you talk to with all of this? You know, who has some knowledge of this? You know, is there anybody out there that you can talk to about this? So open-ended questions along those lines. Typically, also, families need education about treatment and substance use disorders. We need to find out, what do you know about addiction? Most of the time, the people with substance use disorders themselves don't have a lot of education about addiction. Certainly the families don't, and so we're going to ask about that as well. We want to find out what the family members' views of the substance use problem is. Is there agreement there? We also want to determine if there's other problems going on that might benefit from a referral to a marriage or a child or a family therapist. Maybe, let's see, Raul is my client and he and his wife are having lots and lots of marital problems. And Raul says that's one of the reasons why he's using heroin. And so I bring in Raul and his wife and I'm doing an assessment with them and I see this is toxic. They can't even communicate with each other. They're shouting at each other. You know, the wife says, this is ridiculous, I'm leaving. And so in this case, I might realize, like, whoa, okay, wow, this is definitely contributing to substance use disorder and vice versa. But really this couple probably needs marriage counseling. And so I may want to assess that there's a need for supplemental outside therapy. All right. So coming back then to doing the assessment, the first thing we're going to do is we're going to ask the family, what's the problems? What's the concerns? What can you tell me about? I may ask some direct questions too to try and facilitate a response based on the typical problems we see with families where there's a substance use disorder. But our observations are also going to give us a lot of key information. So as the family's telling us about the problems, are they also showing us other possible problems? Maybe I'm asking the family system questions and, dad interrupts every single time. I ask, maybe dad is in there, mom is in treatment, the 19-year-old daughter is in the family counseling session, and the 17-year-old son are there. And I try to ask the kids, so I haven't heard a lot from you two, I'm wondering how you feel about being here today. And the dad jumps in and says, oh, they feel fine. I told them they have to come. This is a family thing. They all need to be there. Okay, great, Dad, thanks. So I'm wondering, if this has maybe caused either of you any stress. Yeah, it's definitely caused them stress, right? And dad jumps in again. Now here, it's not as if somebody in the family has necessarily said, one of the big problems is that dad dominates all the time and none of us are allowed to answer questions. But I can see that that's a problem. And maybe the 19-year-old rolls her eyes, right? The 17-year-old staring down at his lap. Well, that observation of mine is that there is potentially a problem here. And this problem may be contributing to stress or dysfunction in the family system. And so our observations become key sources of information in any assessment. We want to identify how the family members are relating to each other, how they're communicating with each other, how they're behaving with each other, to see if that indicates that there might be some additional problems. Now, much the same way that we talked about earlier, that we need to summarize and repeat back what a family tells us, we're going to do the same thing with our observations. We need to share our observations and any interpretations that we have as part of the assessment. Now, this is often something that an untrained early clinician has trouble with, because there are lots and lots of social and cultural conditioning factors that teach us never share your observations if you see a family as having problems, especially if it's not your own family. But when we're doing clinical work, we really got to fight against that instinct, because we're here to try and be helpful. And if we can't share what we're observing, then we're definitely not going to be able to get any traction on this problem. So using the example that I just gave as the clinician, what I'm probably going to do is say like, okay, so I'm actually noticing, Dad, that you have a really important position here in this family. And I'm noticing as I'm asking questions, you're often the person who's answering the questions, which is great. I appreciate your enthusiasm and how much you're participating. But I think it's really important here that I get a chance to hear from everybody. And I'm wondering actually if this is kind of how it is in the family system, that you, Dad, have a tendency to answer for everybody else. Wondering if you kids see it the same way. Yeah. Exactly. Like, God, Dad, like you never let us answer our own questions. And so what we're going to do is we're going to share that observation to try and find out, do you see this as a problem? Now, sometimes you're going to share your observation and the family will say like, well, no, I don't know what you're talking about. I don't see that as a problem. That's not a concern. When something like that happens, you can say, okay, all right, cool. Well, it sounds like you don't see this as a concern or isn't something that you necessarily want to work on while you're here. No, we got other problems to work on. Great. You want to take that observation and put that in your back pocket, because your observations may actually be correct and maybe the family just isn't comfortable talking about it yet. And there may be an opportunity at a later date to bring that back out and say, I remember earlier talking about, Dad, you kind of being a leader in the family and answering for everybody, and you all had said that isn't a problem, but I'm wondering in this situation if it might be a problem. Yeah, I guess it is. So again, the idea is that you, the clinician, need to help the family to identify problems that they might not be able to talk about, but that they're showing you through their behaviors and their actions and their communication styles. Now, as you're doing an assessment and you're identifying problems, it's also important to consider strengths or identifying family strengths or resources that may be in place. Maybe the family's having a lot of concerns, but maybe their church going and their religion is very important to them and their commitment to going to church on Sundays. And so that might be a strength that, even in the midst of the other things that they're working on, the family's able to get together and it's been a tradition they go to church on Sundays. We may want to highlight that and use that as a support that throughout this process, if you can keep doing what's working. We also may want to identify resources that may be in place. Maybe the aunt has experienced this before because her husband went through treatment himself, and the aunt and uncle can be a resource for this family to communicate with, let them know what's going on, find out what worked for them. So part of the assessment is also figuring out any strengths or resources that they have. There's a couple of other additional factors that typically you want to include in an assessment. One is a tenet of solution-focused counseling, which is to find out what they've already tried. You need to get momentum when you're working with families in substance use treatment because you often don't have a lot of sessions with them. So typically, a key question when doing an assessment is to ask, what have you tried previously to address whatever this particular problem is? There's two sides to that. You want to ask them what worked. If they tried to do something previously and it worked, well, then you want them to do more of that. But you also want to know what didn't work. So if they tried this before and it didn't work, then you probably don't want to try that again. It is certainly possible that something that didn't work previously might work this time around, but most of the time, if it didn't work previously, it's not going to work now, and you don't want to waste time doing that. And related to that is, if they do have tools or solutions that worked previously, then what's stopping them from implementing those tools now? Two other things that are important, they're typically addressed in our AODS 154, our law and ethics class, but a clinician needs to address crisis interventions as needed as they emerge, and often in an assessment, there may be information that comes forth suggesting somebody is thinking of hurting themselves or hurting someone else, like maybe there's suicidal ideation. In that case, then the clinician must assess for that ideation and determine whether there's a plan and a means. In our AODS 159, the co-occurring disorders course, students get trained on suicide, a screening and assessment, and what to do in that situation. But even while doing a family assessment, if something comes up suggesting that there may be a risk, then we must address that crisis intervention. Equally, if there's any indication that a child or an elder might be being harmed, we must report that. That's a mandated reporting requirement. Again, this is talked about at length in AODS 154, our law and ethics course, but in a family assessment, that often comes up. There might be something going on that's impacting children or elders. And then if there's any untreated mental health or medical symptoms that somebody in the family system reports, then there needs to be a referral to a physician in order to address those things. All right, so after we've gathered together all this information, enough information to create an initial treatment plan, it's probably worth saying we're not going to get every single possible problem that this family has going on, but we're going to try and get the big picture of what the priority pictures are. So after we have that, then we're going to summarize. So as I had said previously, you're going to repeat back to the family the list of problems and strengths that they told you about, but you're also going to repeat back to the family the things that you've observed. This act of summarizing provides clarity and it confirms that you've heard them. It also identifies any misunderstandings or misinterpretations. You might have misunderstood that something's a problem, and then when you do the summary, they let you know, no, that's not a concern. That's not what I was saying. What I was saying is this. There's lots of evidence that a clinical summary simplifies often very complex and complicated ideas. Go back to the example of Maria's mom, who's being kind of disfluent and unable to clearly identify what she's concerned about. And when I do the summary, I say, so Maria's mom, one of the things that you brought up that's really important is that while you support Maria and you're happy to take care of your grandkids, you need to find some balance so you can take care of the things in your own life. It's a much more simple, concise way of saying what the problem is. And there's evidence that when people hear a summary or things like this reflected back to them, they feel better, where maybe Maria's mom's like, yeah, exactly, thank you. The other thing is that in doing the summary, it allows us to monitor and assess the family's understanding of their own issues, to see not only if I got it right, but if the family sees this, understands this in the same way. Now, in the family counseling class in the AODS program at City College, students practice assessment and summaries over and over and over again. From very early in the semester throughout, we create scenarios where some of the students are family members, some of the students are counselors. Students get ample opportunity to do assessments and identify problems and share their observations. Students also get lots and lots of practice summarizing and repeating back to families what it is that they've heard. These are skills that need to be trained, and they're skills that take active practice. And so we make sure to provide lots of opportunity to do this active practice so that when the student leaves the AODS program and goes out into the field and is working in actual substance use treatment facilities, they've had the opportunity to do assessments and summarizations with family systems already in a mock scenario so that they're more comfortable and they're working with an actual family that's sitting in front of them. The last part of doing an assessment is interesting, and it came out of some actuarial or insurance-based research. What they found was the initial research was done with individuals, but it applies to families also. What they found was that people would often wait. They'd sit on a waiting list to try and get into treatment. They'd go to one session and they wouldn't come back. And they were trying to figure out what is going on. Why would people wait to get into treatment and then they only go to one session? And what they found is that clinicians were doing an assessment in the first session, as understandable, part of the golden thread, part of the process to develop a treatment plan. But people would come in and they don't know what treatment is, they don't know what assessment is, and they get in and they talk about all their problems, and at the end, the clinician's like, okay, great, well, this is perfect. So next time we meet, we'll work on the treatment plan. See you next week. And people were walking out the door feeling like, well, that wasn't helpful at all. Like, I mean, all we did was talk about our problems. I don't have any idea how to make my problems better. That was a waste of my time, waste of my money. I'm not going back. And so what they did was a study that has since been replicated where they had people enter treatment and both went through an assessment, but one group simply did an assessment. The second group did an assessment with an identification of some small initial tasks that could be accomplished between that session and the subsequent session. And what they found significantly is that people that had some small initial treatment goals or tasks to do tended to come back at much higher rates than people who didn't. And so now it's considered best practice that when you conduct an assessment, at the end of the assessment, you want to identify some small goals or tasks that the person can work on before the next session. So when we're working with a family, we're going to do the same thing. We're going to try and see if the family can agree to accomplish some small, realistic goal. Now, small, meaning tiny. We want something that is not complicated. We want something that should be very easy to do between now and the next session. Because if we create a very complex goal and the family isn't able to carry through, then they're going to tend not to come back. So small, realistic goals is something that the family can work on together. Something like having family dinner together would be a small, realistic goal. Coming up with a list together of the things that you want to work on in family counseling the next time you see each other, that's a small, realistic goal. Attending one Al-Anon meeting between now and the next session would be a small, realistic goal. So again, in the AODS program, these students have many, many opportunities through our scenario-based learning to help work with our mock family system to develop small, realistic goals that can be accomplished before the next session. Like any treatment goals, these goals need to be specific. They need to be measurable, meaning everyone's clear how many or how often we're doing this and when it's supposed to be accomplished. And sometimes small goals, like maybe you're working with a couple and the goal is, I'm wondering if you two could contact your insurance company to find out if there's any marriage therapists that are in your insurance plan between now and the next session. That may simply be the two of them contacting a family therapist or marriage therapist. So the idea is get some small goals so that they can accomplish that, feel good about that before they come to the next session. All right. So the review of assessment in general and family assessment in particular is that there are 3 stages. You identify problems first by listening, observing, and asking questions, and you're going to clarify whether these are problems they want to work on in treatment. You're going to summarize what the family's told you, and you're going to share those observations and interpretations of other potential issues to work on together. And then you're going to identify and try and get agreement on some small initial treatment goals to work on before the next meeting. So, for those of you that attend the AODS program at San Diego City College, if you were in the classroom setting and you just heard a variation of this lecture, this would be the time where we would break off and we'd put people into families and a whole bunch of people to be clinicians, and we'd get lots and lots of practice. So now you've had the opportunity to learn all about assessment and family assessment, and hopefully these lectures are encouragement for you to consider perhaps enrolling in the AODS program at San Diego City College. Until next time, you now know how to do assessment.